So it is my pleasure to introduce our first speaker. Dr. Troy LaBounty is a cardiologist at Michigan Medicine's Cardiovascular Center and Chelsea Health Center. He sees patients with a variety of cardiac conditions and a clinical focus in heart valve disease. He's published and lectured extensively on the use of cardiac imaging to diagnose and manage patients with coronary artery disease and valve disease, has expertise in cardiac CT, transthoracic echo, and TEE. So we are very excited to welcome him to talk to us today about cardiac CTA. Thank you so much, Dr. LaBounty.
Thanks so much, everybody. Appreciate being here, and thanks for inviting me. One thing I forgot, I always forget something. If I point, does anybody see anything if I point on the, oh, perfect, okay, all right. So I'm going to talk about coronary CT and calcium scoring. Any questions, please feel free to ask questions as we go through. I'm going to start with a case example. 57-year-old man comes into the emergency department with hyperlipidemia, has a history, and a few days of chest pain. Usually it's exertional, but not always. Occasionally it's happening at rest. It's a substernal chest pressure, no other symptoms. Troponins are negative. The EKG has some intermediate findings. And then, so, what are our options from here? And so really somebody coming to the emergency department with chest pain and, a further evaluation may be warranted. And we really have a lot of options. We have options of stress testing. We have options of coronary CT. Could be done as an inpatient or in the ED or as an outpatient. Sometimes just deciding that it's low likelihood and not doing testing is an option. I think in this case, most of us would consider testing. And this patient had a coronary CT scan. So, and let's see. Yeah. Okay, great. So this is what the CT showed. So this is the left anterior descending artery coming down the front of the heart, looking to see if there's narrowing in the artery. So that's one of the things that we look at on coronary CT. And you'll see that right here, there's an area that looks really narrow where you don't. So this is contrast coming down the artery, and there's a little area where you don't see that contrast that looks like it's severely stenotic. But CT gives you a lot more information than just looking at the lumen, which is one of the cool things about CT. So even if the left main, which looks pretty okay, if you just look at this view, if you look at sort of a short axis slice through that left main artery, this is actually the vessel right here. This whole thing is the vessel. The lumen is this little bit right here. So there's a lot of plaque here in the left main. It's just not just a normal left main. There's a lot of plaque. There's a relatively preserved lumen. If you go down the artery, even down here where it looks like the artery doesn't look too bad, there's certainly plenty of lumen here. You see all this stuff around it. This is all plaque. So this is something called positive remodeling, where the artery stretches outward, kind of dilates to accommodate, to kind of preserve the lumen, but accommodate the plaque that's present. This is considered something that could potentially be higher risk, put patients at future risk of acute coronary syndrome. But a lot of plaque. If you look at sort of a slice through there, right over here, you see that this is lumen right here, but the vessel, the interior, where there's blood, but this entire thing is the vessel. So this is all plaque right here. So a lot of plaque. And I'll skip down here to this really tight area, and that's if you do a kind of a slice right through that. This whole thing is the vessel, but the lumen is this little bitty thing in the middle. So this is where it looks really severe. So what this is showing you is that CT gives you a lot of information in addition to just looking at the lumen. You can see plaque, you can see characteristics of the plaque, and sometimes these can be really helpful. And this is what the cath showed. So, very similar, very tight stenosis here in this artery. Just looking at the other arteries in this patient, here's the right coronary artery, and on the bottom left you see the CT scan. There's a little bit of plaque, nothing too exciting. And the similar, you see it on cath. You see some irregularities of the lumen, just kind of showing you that it's not smooth. So there is a little bit of plaque there. Here's the circumflex, and you can see this kind of long segment where there's actually, let me start with the CT. You can see this area right here where there's the artery is kind of stretched outward, because this is all artery. This little thing is a little focus of calcium. This is all plaque over here, and then here's your lumen over here. So the artery is kind of stretched out, and this is some of the things that CT can show you. And the cath, you can't really see the plaque on a cath because you're usually seeing the lumen. You're not seeing the vessel wall. You're not seeing plaque that might be present. You can do similar things invasively with intravascular ultrasound or other techniques where you go down an artery and take images, but just with an injection of contrast on the cath, you don't see these types of things typically. So as we think about something like coronary CT, there's a bunch of things we want to think about. Is it, number one, is it an accurate test? Does the findings on a coronary CT, does it have prognostic value? Does it mean something clinically for the patient as far as their prognosis? What's some examples of when coronary CT is appropriately useful? What about safety, like radiation? And then what are some new things in coronary CT that we think about? So I'm going to try to highlight a few of these. So when we think about accuracy, there's been a ton of studies looking at the accuracy of coronary CT. CT is very accurate to identify coronary artery disease. If you have coronary artery disease, CT is very sensitive at identifying it. Not quite as specific. In other words, if you see a tight lesion on CT, you likely have a tight lesion on CT. If you don't see it, but you can also overcall a tight lesion on CT compared to cath. When you look at some of the meta-analysis out there, they say sensitivity in this particular meta-analysis, sensitivity of 100%. In reality, it's a little bit less than this. Here they exclude some patients and things. And a pooled specificity of 89%, which is still really good. This is a more recent meta-analysis that includes some of the older CT technologies. So the results aren't quite as high. They report a sensitivity of 94%, specificity of which is very good, a specificity of 79%, which is good. But what I really like about this one is how they break it out to let you think about, when should you be ordering a coronary CT in patients. So when you think about any test, you want to think there's always going to be tests where you find false positives and false negatives, where you miss disease or you overcall disease. No test is perfect. And CT is one of those. If you take somebody that has a really low pretest probability of disease, of coronary artery disease, like maybe somebody in this room with no symptoms, no risk factors, for example, let's say it's a 5%, really low. Even if you have a positive coronary CT suggesting that you have coronary artery disease, you still have a really low risk, really low likelihood. Let's say it's like 5%, which puts you about here. You'd still probably be about only 20% likelihood to actually have disease if you did a cath. So CT can overcall things. Let's say you're way over on this end. Let's say you're almost certain somebody has coronary artery disease, really high likelihood, 90%. If you test them and the CT is negative, you still have about a 20% chance that they have coronary artery disease. So CT is not good, and most of our diagnostic testing is not good at the extremes. It's really helpful in the intermediate risk patients. So this is a great example. So if you have a 33% pretest probability of coronary disease or intermediate risk, and you have a positive CT, your post-test probability is 81%. So 8 out of 10 you have coronary artery disease. If you have a negative coronary CT, and with a pretest probability of 33 and it's negative, post-test it's almost zero. So maybe 1%, 2% if you extrapolate it over. So it's very good in the intermediate risk populations. Not good at the extremes where you really high pretest probability or low pretest probability. So, what about prognostic value? So, early on with CT, there was a lot of data showing it was accurate compared to cath. But a lot of the criticisms were, so what if it's accurate? Do the findings actually mean anything? And we didn't actually know earlier on in the days of coronary CT. So let's say you have the same 60-year-old female coming in with chest pain. On the left, you have somebody with a normal coronary arteries. In the middle, you have somebody who has some plaque. It's not obstructive. So it's a mild plaque, not causing decreased blood flow down the artery. And over on the right, you have somebody with a chronic total occlusion of the right coronary artery. Does that mean anything if you see it on CT? Probably you would think it would, but we didn't actually have the data earlier on. And then there's been a host of studies that have come out looking at, answering the question, does CT have prognostic value? This is one of the earliest ones, basically showing that if you have any plaque on CT, you have more mortality compared to patients who have normal coronary arteries. So even a little bit of plaque present on CT suggests higher rates of mortality. And if you have multiple, 1, 2, or 3 vessels of coronary artery disease, higher risk of mortality. There's been a bunch of literature kind of looking at this, kind of validating that CT findings have prognostic value in symptomatic populations. In asymptomatic populations, it probably does not have significant value on top of traditional risk score assessment. So the PROMISE trial was a really large study looking at 10,000 patients with chest pain who were randomized to either coronary CT or stress testing, functional testing strategy. What they basically showed, so this is asking the question, so you have somebody with chest pain. Should you order a stress test? Should you order coronary CT? Is one better than the other? And this test basically showed that there was no significant difference between ordering coronary CT or a stress test on outcomes. One of the challenges with this trial is that it was a sort of used a smorgasbord of the stress testing. Most patients had nuclear stress testing, few had stress echoes, some people had exercise EKGs alone, some people had no stress testing. But they did not show that CT or stress testing was superior one versus the other. Another study, the Scott Hart trial, came out a couple years ago. That looked at 4,000 patients with stable chest pain who were randomized to standard of care plus coronary CT versus standard of care, and they waited until you made your initial plan before they randomized patients. So basically asking, should we do the standard of care, which is what doctors would normally do, or should we order a coronary CT? And the patients that were randomized to coronary CT had much lower rates of death and non-fatal heart attacks. This sounds great for coronary CT, right? It makes it sound like, wow, you can greatly reduce, bad things happening if you have a coronary CT compared to the standard of care. And yes, this is what they observed, but you have to look into the data a little bit too. And what you actually see is that, and this was done in Scotland at multiple sites, most patients there were not getting stress imaging tests. In the United States, most patients who are getting stress tests, it's much more common to have stress echoes, stress nuclear than just an exercise EKG alone without imaging. And what they found is that basically 86% of patients only had an exercise EKG. So really what this tells you is that standard of care, where almost 90% of people are only getting an exercise EKG, is not as good as coronary CT. But it doesn't tell you really, it'd be really interesting if they had a different type of test that they used. So coronary CT has clear prognostic value. I think it's a valuable tool for us, for our patients. It's accurate. And then I want to show some cases of kind of typical appropriate scenarios where we like to use coronary CT where it's considered appropriate by guidelines and is helpful. As we think about the recent new chest pain guidelines, the multi-society chest pain guidelines that come out, I really like this slide because it highlights this really nicely. But basically, when you think of somebody coming to the emergency department, that's acute chest pain evaluated in the ED. You think about whether they're high, intermediate, or low risk, and there's different ways to do that. But really, if somebody's high risk or if they're having acute coronary syndrome and they have acute chest pain, you're probably going to do a cath, and that's typically appropriate for a lot of these patients, just an invasive coronary angiogram cath. Intermediate patients would typically be appropriate for either coronary CT or stress testing, anatomic or functional testing. On the outpatient scenario, people with stable chest pain, it's a little different. High risk or intermediate patients can be appropriate for functional testing or coronary CT, so stress testing or coronary CT. And then for everybody, basically, if you're low risk or asymptomatic, we generally don't test outside of certain circumstances. This is a bit of a controversial figure that was in this consensus document. What they're basically asking is, or suggesting is, when should we use coronary CT? When should we think of a stress test in patients with chest pain? And what they basically, if things that would favor the use of coronary CT, if you want to rule out obstructive coronary artery disease or see if somebody has a little bit of non-obstructive plaque, that a CT would be really good for that. If you want to look to see if they have ischemia, decreased perfusion, decreased blood flow down a coronary artery, stress testing is typically going to give you the answer. Obviously, a lot of weight goes into what's your local expertise. Is your site really good at coronary CT, but not very good, not as good at stress testing, for example? That would kind of shift you to which way you would order. This one I don't necessarily agree about. Younger patients under 65 favors using coronary CT. Older patients greater than 65 favors stress testing. It's not completely unreasonable, but there's risks too with especially with younger patients. I'm always reluctant to give them any type of testing with radiation. And coronary CT doesn't have a lot of radiation under many circumstances, but it does have some. And I think you want to tailor the decision for these to patients. And a lot of times we have discussions with patients. Here's our options. We could do a coronary CT. We could do stress testing. Here's the pros and cons of each, and then kind of think about it. So, yep, there we go. So here's a couple cases I wanted to show. So here's a 44-year-old female runner who runs about 6 miles a week. And she's had recent chest pain during a hard run, and then she had a repeat episode that came on at rest while she was driving. So always concerning when somebody has new exertional chest pain, and then it potentially comes on with rest. This could be cardiac, this could be non-cardiac. And she was seen in the emergency department. They referred her for a cath as an outpatient, and was seen by one of our interventional cardiologists who suggested a coronary CT instead. And she had completely normal coronary arteries. So in this case, it appeared to be something not cardiac. Maybe it was acid reflux, something else. But this was a very good example of a coronary CT potentially avoiding somebody going to a cath without high-risk features. And this also highlights some of the radiation issues. This was done with a very low amount of radiation, 0.6 millisieverts. Our background exposure in the U.S. per year is about 3 millisieverts. It's much higher in Denver. This calculates out to if you went to Denver for 6 weeks, so it'd be the same amount of radiation that you would get. So really low risk, low amount of radiation. But a very helpful test. Here's another case, a 69-year-old. This is one of my clinic patients, incidental diagnosis of a cardiomyopathy. Somebody did an echo. The echo EF came back at 30%. He felt fine. So he had left ventricular dysfunction without heart failure. And anytime we see left ventricular dysfunction, we want to look at, is there coronary artery disease that could be playing a role? It's one of the most common causes of heart dysfunction. So we did a coronary CT or aortic coronary CT. And what we found is his coronary arteries looked sort of okay. He has an intermediate amount of plaque in his LAD, but the remainder of his arteries didn't have anything. We medically managed him, and he's done well over the years. So CT can be very appropriate in assessing patients with reduced left ventricular function. Here's a 62-year-old with hyperlipidemia, came in with acute chest pain, acute shortness of breath, breaking out in a heavy sweat, all kinds of things that make you think about acute coronary syndrome. But she had negative troponin, so maybe this is unstable angina, maybe it's non-cardiac chest pain. And she had a coronary CT, which showed a very, very tight lesion in her artery right here. Most of the artery looks okay, but you can see there's a really, you can see this really tight spot right here. And if you do it on a short axis, kind of slice through right there, this whole thing right here is the artery, and this little thing right here is the lumen. So, and this looks like sort of unstable. We would, in a scenario like this, this would be what we'd be concerned about, unstable angina, acute coronary syndrome. She underwent a cath, which stopped playing. Here it is right here. So here you see that really tight lesion right there. So she was treated with a stent and did well. Here's a 76-year-old gentleman that came to the emergency department. He had chronic stable angina, had a history of 4-vessel bypass, 7 stents, including to grafts, and he had a big aorta. So on the differential with acute, with chest pain was aortic, something going on with the aorta. So they ordered so he had this chronic stable angina, but he had some more chest pain on top of that. So they ordered an aorta protocol CT to evaluate the aorta. But as sometimes what happens in the aorta protocol CTs, we see grafts really well. We can sometimes see the coronaries reasonably well. And that's the case here. So here is his graph. So here's the right internal mammary artery that runs right down the inside of the chest wall. That is not being used for bypass, but they did use the left internal mammary artery. You can see they basically took it down from the chest wall and brought it down here and attached it to the left anterior descending artery. And that looked fine. Here are little markers to where they did the vein grafts. So there's a vein graft that's from here with a stent right inside. You can see the stent kind of bulging out there, and then it kind of comes down and touches down to this diagonal artery. And then there's another bypass graft right here that comes off. You can see a stent here as well that kind of comes down over here and touches down to obtuse marginal. So these are kind of cool images on CT that kind of help you understand anatomic relationships. You can't use these images to diagnose whether there's tight narrowing or not, but it's just a reconstruction of the heart to kind of give us three-dimensional visualization of how things are connected. Then we stretch it out. These are the diagnostic images on the same patient. You can see that Lima graft going down to the left anterior descending artery was fine. The vein graft, here's the stent right here, going down to obtuse marginal was fine. And then we had a vein graft to the diagonal, also with a stent inside that was fine. Now, one of the things I like this is helpful to show is usually we don't like to image stents on coronary CT because coronary CT usually can't see inside of stents unless they're larger stents. In this particular case, though, we did a reasonable job of seeing inside of these two stents. 12 months later, the patient came back to the ED with worsening chest pain. And again, the ED ordered an aorta protocol CT. This was not a coronary, but it was an aorta protocol. And we were able to actually take a look. And, one of his grafts had gone down. So you can see here's the original CT with this graft that was open. And then you can see that there's a missing graft here. There's a stent that's all dark inside. So this graft had failed. So that was the explanation for his chest pain. Nothing going on with the aorta. But typically, if a question is, are grafts patent post-bypass surgery, CT is very good at looking at graft patency. They don't move as much, so we have less motion issues. But CT typically has a hard time with stents. But in this case, it was actually really helpful. Here's a stress echo. So I spend a lot of my time reading echoes. These are some different views of the heart. And what we do in a stress echo is you basically take some images of the heart at rest, run somebody on the treadmill really hard, and then they jump off and you take quick pictures before the heart slows down. Or you can give them dobutamine and have the heart rate go up and then image the heart at peak dobutamine, which makes the heart go fast and beat really vigorously. And you're looking for wall motion abnormalities that happen with stress. In this particular case, this is the two of the walls of the heart that we look at in this view. They augment really nicely. They look good. Here's a short axis kind of slicing through the heart. And you can see this is at baseline. Sorry, the upper left is baseline and the upper right is after exercise. So this does what we want it to do in the upper right. It becomes really vigorous post-exercise. Bottom left is rest. All the walls are kind of coming in and then you can see with stress, it's even more vigorous and all the walls are coming in. So this looks nice and normal. Here's the other views that we get. These are two of the other walls that we look at. This is at the upper left, this is rest, and the upper right is peak stress. This looks really vigorous. The wall motion looks fine here. And then if you look in the bottom left, this is at rest. There's one wall we don't see very well down here. This is the proximal inferior wall. And then here's the post-stress images. And again, we don't see that little segment down there very well. So this was called, concern for possible ischemia involving that basal inferior wall. Hindsight's always 20/20. When I look at this, I typically don't call this wall motion abnormality. I would typically call this normal because this is it's a long ways away from the probe and it's often overcalled. But the reader called it as abnormal. So the patient had a coronary CT, and the coronary CT showed normal coronary arteries. So point being that if you have an abnormal stress echo, an abnormal stress test, a coronary CT can sometimes be helpful if you suspect that it might be an incorrect call on the stress test. Another example of the same type of thing, 67-year-old with a year of chest pain, happening with exertion, had a normal SPECT stress test. Oh, actually, this is a different case. I have another one like that coming up. And had a left heart cath that showed a coronary anomaly. And here you can see an ejection. This patient has essentially a single, all the arteries come off one left main from the heart. So normally there's a left main that gives off two main arteries, and then there's a right coronary artery that gives off another artery. So this patient was just born with arteries that are connected in a different way. And sometimes these can cause problems. In this particular case, this is the patient underwent a CT to get a better idea of the three-dimensional relationship of things. And what it showed is again, everything comes off this single artery right here. And when we kind of lay it out, you see that the left anterior descending kind of courses between the aorta and the pulmonary artery. And this can cause angina and sometimes be significant and is often treated, sometimes with surgical ligation and like a graft to this artery. Here's another case just illustrating concern for a false positive stress test. 62-year-old female with a new left bundle branch block on an EKG, which can suggest ischemia or a coronary artery disease. And the patient was also having episodes of throat tightness, concerning for maybe being an anginal equivalent. So she had a nuclear stress test done, and it showed a reversible defect in the septum. And this is something that we can often see, and this was a patient I saw in clinic, and she came to see me with this positive nuclear stress test. And you know, anytime we see something like this, where there's when you have left bundle branch block, part of the heart moves in a funny way, so it can cause false positive stress tests, or stress tests that suggest that it's abnormal, but they're wrong. So we did a coronary CT, and she had completely normal coronary arteries. So left bundle branch block can be kind of tough to do stress testing in some patients, but coronary CT is not impacted by it. So those are a bunch of scenarios where coronary CT can be an appropriate test. It's a really useful test for a lot of our patients. We have to think about some of the safety issues too, and radiation dose is one of the big ones. So early when coronary CT came out, this was the Protection 1 study, which is a really, really important study that I think highlighted a lot of potential concerns. This was almost 2,000 patients from 50 sites around the world, and the radiation doses range from 4.6 to 30 millisieverts. Some of these are relatively low radiation doses, some of these are really high radiation doses. And the median dose was 12 millisieverts, which is, if the background radiation here in Michigan is about 3 millisieverts a year, it's like getting 4 years worth of radiation. So there is a concern about potential risk. This is another paper that came out about the same time that I like to show, because I think it just highlights the theoretical risk. If you had this is not modern coronary CT, but if you had a coronary CT back in 2005 or so, and you were just a coronary CT, and you were a female, that's the dark line right here. Women are at higher risk of cancer from radiation from a CT scan of the chest because of breast tissue. If you had a standard coronary CT and you were 20 years old as a female, you would have a 0.7% likelihood of having cancer during your lifetime from the radiation. That's kind of a staggering number, right? So men had lower risk, and as people got older, that risk went down. But we certainly don't want to do a test that is going to put people at substantial risk of cancer. So this got a lot of attention, these two papers, and it prompted people to start thinking about strategies to lower the radiation dose on CT, and they were very effective. So there's a lot of studies looking at how we can lower radiation doses, a lot of things that can be done. But this is an example of a 60-year-old patient that we scanned, where we used a bunch of dose reduction techniques, 0.5 millisievert of radiation. Again, remember that the median back on this study was 12, and it went from 5 to 30, and here we are at less than 1. So, this is where we start to get to relatively safe doses. The chest X-ray is about 0.1 millisievert. So this just kind of highlights where we're at. You know, a SPECT nuclear stress test, if it's they're doing both stress and rest using some of the older but commonly used isotopes. The radiation dose is somewhere around 25 millisieverts, so it's a relatively significant amount of radiation. There's some strategies that can lower the risk, and I know several sites use strategies, including at our site, we use strategies to lower risk. We do a lot of PET scans, which has lower risk as well, depending on which one you do, much lower risk. Here's a cath, about 7 millisieverts is what's often quoted. That's just a diagnostic cath. Calcium score is about 2 millisieverts. Here's where CT was way back in like 2007, and you can see it really has come down to much lower doses. So it's become a much safer test. This comes out of the imaging consortium that Blue Cross Blue Shield funded several years ago, but this was one of the major studies that came out as well, looking at 5,000 patients at 15 Michigan hospitals, and they kind of had a control period where they looked at what the radiation doses were. It was 21 millisieverts, median dose, so a lot. And after giving feedback and recommendations to sites, they brought it down to 10 millisieverts. And then they followed it for over a further period of time, and they brought it down to about 6 millisieverts. And it's, as far as I know, it's stayed in that. I don't know that it's been assessed in the last several years, but it's stayed in that area. And the reason we can't, it's still 6, it's not down to like 1 or 0.5 or something, is Michigan patients tend to be bigger. Bigger patients require more radiation so that we can see the heart. Our typical dose for most patients is probably 2 to 5 millisieverts, depending on body size. Bigger patients requiring more, smaller patients requiring less. So CT's got it in a lot safer. And I think that was really helpful to get some of that attention drawn to the radiation safety early on. I still would be reluctant to do a coronary CT in a really young female without if we didn't have other options, but sometimes we would want to. So now I want to just move on and talk about some other, and I just have a couple slides left. I want to just talk about a few areas that are of interest, future directions of coronary CT. So there's a lot of interest in looking at high-risk plaque features, people that might, if we see something on CT, might represent a future acute coronary syndrome or something that could lead to plaque rupture and MI or death. And there's several findings on CT that can be helpful with that. I'm not going to go into detail. I want to just have a couple slides on non-invasive fractional flow reserve, because this has been a particularly intriguing topic in coronary CT for the last several years. We've started doing this just over the past couple years at U of M, for example, and I know many sites in Michigan are doing this. And so what a CT tells us, we can look at it, see is there a stenosis of an artery and how tight is that? What's the plaque? But CT doesn't tell you is that significant or not. Is there a significant reduction in blood flow down that artery? And what fractional flow reserve CT does is you basically take the standard CT data set, send it to a company in California that then does three-dimensional modeling and computational flow hemodynamics to kind of estimate, is that lesion causing stenosis, causing decreased blood flow during that artery or not? And there's a lot more complexities than is it 50% stenosis, is it 70%, which is sort of an eyeball estimate. There's a lot of things that are subtle that, is it a long lesion? Is it a short lesion? Is it before artery branches or after a branch point? They can affect whether it's significant or not. So they attempt to do a lot of modeling looking at that. And this is a recent case that we did, a 78-year-old female with chest pain. She had a really big thoracic aortic aneurysm in the emergency department and was planned for aortic surgery. So pre-op, they did a coronary CT, which showed a long 40% stenosis of the LAD, kind of right around here. There's also a lot of calcium, which makes it hard to see. So we did a FFR-CT was performed. And the FFR-CT, basically when they extracted it and ran it through the computers, suggested that this might be a significant lesion. And the patient underwent a cath, which agreed with the 40%. They did not do invasive FFR, which they could have, but they did not feel that it was warranted, and it was felt that this was not hemodynamically significant. So this is the case where FFR-CT could have overcalled a lesion, but it can be really difficult. If you got a lot of calcium on a CT, it can be hard to know exactly where the lumen is sometimes. So, extrapolating and trying to figure out what this lumen is can be difficult. So there's a lot of interest in FFR-CT. There's also issues with if you do a scan and you have to send it to somebody else to process in California and wait a day or a couple days for it to come back, for then you to be able to complete the report. It delays things a little bit. An alternative is doing a coronary CT and then doing a stress test or something if you have a lesion that you're concerned about. But the nice thing about FFR-CT is it doesn't require the patient to do anything else. I'm going to kind of skip this in the interest of time. I'll just show a couple slides on calcium scoring. So calcium scoring basically looks at whether there's calcium in the coronary arteries and adds up how much calcium is present. And we know from a lot of data that if you have a lot of calcium in your arteries, that puts you at higher risk than if you have no calcium in your coronary arteries. And this is just an example of a patient that we did last week where they had a coronary calcium score that was pretty high, 463. And what we do is we kind of look at them on and some of the data that's out there and plot them by race and gender and age against what would be expected. And in this particular patient, they're above the 95th percentile for age, race, and gender. So a high amount of coronary calcium. We know that more coronary calcium suggests that people are at higher risk. There seems to be some significant differences between different ethnicities, but the data we have is really incomplete. It's really whites, African Americans, Hispanics, and Chinese. What about Japanese? What about Hispanics of different parts of the world? Central America versus South America, for example. What about other ethnicities? We don't really have good answers to that. So it's kind of it's a little bit challenging to separate people into these categories sometimes. But we do know that the higher calcium score you have, the higher amount of your risk of death. And it's a measure of calcium scores measuring up calcified plaque in your coronary arteries. It doesn't include the non-calcified plaque. This is one of the studies that was really initially kind of exciting. It suggested that calcium scores, if you were asymptomatic, had at least one risk factor for cardiovascular disease, calcium score added to the Framingham risk score for predicting people who are more likely to have bad things happen, death or heart attack. So that suggests maybe we should be screening patients with calcium score CTs. But the data out there is not so clear. So this was a nice study done, a randomized trial in 1,000 asymptomatic patients with high calcium scores, and they were randomized to statin plus some vitamins versus placebo, and they got another calcium score at 2 and 4 years, and they looked at outcomes. And there was no difference in their calcium score between the groups that were on a statin or not, or vitamins or not, and no difference in whether people died or not, whether they were on a statin. So this study didn't show that using a calcium score to guide management changed outcomes. But it's still considered appropriate for patients who are at intermediate risk of cardiovascular disease to do a calcium score. It's an option if you're trying to risk stratify patients to statins or no statins. So I'm going to kind of skip this slide in the interest of time. But just to summarize, so coronary CT I think is a really useful test. It's accurate, has a lot of appropriate indications, has value. It's generally a low radiation dose. Calcium score can be helpful in some patients. It's not clear if using a calcium score changes people's outcomes. And it's also not covered by insurance typically, so people pay out of pocket for it. So thank you. Any questions?
Hey, Troy. That was an awesome talk on like a really complicated subject. One of the things that it's more of just a comment, but one of the things that I've been thinking about is how much I love patients who come to the cath lab after they've had a coronary CT, because we often get referred patients who had a bypass 10 years ago in Iowa or something like that, and we don't know where the grafts are or how many grafts there are, and we have an entire roadmap of where we're going. And I'll bet that patients who have had coronary CT that then go to cath, I bet if we studied it, and maybe it has been studied, that their procedures are actually safer, shorter, and have less radiation. And then when we're going to do an intervention on someone, we know exactly how the artery is going to twist and turn, how much calcium is in the lesion. There are really no surprises. So it's really awesome. And I think in patients who screen positive and eventually go to cath, it's absolutely super useful for us.
Yeah, no, and I skipped over one slide. There's a lot of interest in using a coronary CT as sort of a gatekeeper to cath. There was a sort of a pivotal study about 10 years ago that showed I think it was 80% of patients who went to a diagnostic cath did not have obstructive coronary artery disease, and most of them, their only test before a cath was a EKG. And I don't think that's what we experience at our hospital, and I think a lot of hospitals not necessarily do that. But overall in the United States, a lot of people go to cath without stress testing, without coronary CT, and having some type of test, whether it's a stress test or coronary CT, sort of as a gatekeeper before you put somebody through an invasive test, could save on costs, could save on safety and things like that too. And yeah, I think it can be really helpful. If you have a stress test that shows there's an area of the heart that doesn't have enough blood flow with stress, it can be kind of helpful. If you go in and do a cath and you see that you see an intermediate lesion, it can be kind of helpful to know whether that would be useful to stent or not. Yeah, I think CT has a really good role to play. It has its challenges as well, as we talked about. No test is perfect. CT does not work well with stents, and I didn't mention, but people who have faster heart rates or who are an AFib, we typically have a hard time seeing the coronary artery. So we need to get the heart rate close to 60. We need people typically to be in regular rhythms to be able to do a coronary CT that's going to be accurate. Yeah, I think the contraindications would be known stents. Typically, if somebody has a stent and somebody's ordered a coronary CT, we'll call them up and say, we probably can't see inside of the stent. We'd suggest a different test. People with horrific coronary calcium, they can be hard to read, but it's still not contraindicated. We can usually still do a pretty good job with people with a lot of calcium. But typically the contraindications would be, you don't want to give them radiation for some reason, like a pregnant woman, or it has a coronary stent, or we're unlikely to be accurate if we have fast heart rates, can't get the heart rate close to 60 to 70 is usually okay, or if they're in an irregular rhythm. That's where we run into trouble.
If you have questions, you can enter them into Slido, or Kathleen and I have microphones. We can walk around to you if you raise your hand.
Thank you very much.